everyone, we are from Group 2IT and now we will explain about the Patophysiology and Nursing Care Plan for preterm labor. Okay, the first one is about the definition. The definition of preterm labor is labor occurring between after 20 and before 37 weeks gestation. The preterm labors are subcategorized as early or late preterm. Early preterm labors occurs prior to 33 weeks gestation, and late preterm labors occurs between 34 and 36 weeks gestation. The second one is classification. The birth of premature babies can be divided into three. The first one is borderline premature babies. So in this type, the baby born at 37 weeks gestation period and about 6/10 of all live births. The baby's weight is around 2,500 to 3,250 grams, and the labor is usually normal. The problems that often occur are instability, difficulty breastfeeding, and jaundice. And the appearance is few folds on the legs, smaller breasts, lots of lenigo, and underdeveloped genitalia. The second one is moderate premature baby. The baby is born around 31 to 36 weeks gestation period. The baby's body weight is around 1,500 to 2,500 grams, and about 6 to 7 of all live births. The problems that often occur is instability, glucose control, icteric anemia, infection, and also difficulty breastfeeding. The appearance like that of a borderline premature baby, but more severe. The skin is thinner, more blood vessels are visible. And the third one is the baby is very premature. The baby is born around 20 to 30 weeks gestation period, and the baby weight is just around 500 to 1,440 grams, and about 0.8% of all live births. The problem that often occur is all that I have mentioned before, and the appearance is small, has no fat, very thin skin, and both eyes may be closed together.
For the etiology, the following are etiology that may contribute to preterm labor. They are stress, infection, placental abruption, placenta previa, substance use, history of preterm birth or abortion, inadequate prenatal care, smoking, maternal age less than 18 or more than 40, poor nutrition, low body mass index, fetal anomaly, fetal growth restriction, oligohydramnios, polyhydramnios, vaginal bleeding, premature preterm rupture of membrane or PPROM, and environmental factors. This list is not comprehensive and various other factors contribute to preterm labor. However, it encompasses the most common reason patient present in clinical settings.
Okay, now we want to talk about pathophysiology of preterm labor. Components contribute to labor. There are three. First, cervical changes, two persistent uterine contractions, and also activation of the decidual membranes. Normal labor is normal physiological process, and preterm labor is pathological, acute, or chronic, or several weeks leading up to labor. Key events is fetal inflammatory response syndrome, or FIRS, and also involves systemic inflammation and elevation of fetal plasma interleukin 6, typically in response to a trigger such as choriomyonitis, and a signal is sent by the fetal hypothalamus leading to secretion of CRH, stimulating the release of ACTH, and therefore cortisol production by the fetal adrenal glands, which triggers the parturition pathway to activate. An influx of inflammatory cells into the cervical stoma leads to the release of cytokines and prostaglandins, which stimulate cervical ripening. These changes influence the structures of the collagen and glycosaminoglycans that make up cervical tissue. Estrogen stimulates collagen degradation, whereas progesterone inhibits. Therefore, progesterone is used to prevent or delay ripening, and both hormones are implicated in regulating the gap junction formation and the upregulation of connectin 43 proteins, which contribute to parturition. Additionally, contractions are an integral contributor to labor. The change from uncoordinated myometrial contractions to coordinated uterine contractions is attributed to neural control. Oxytocin plays an essential role in the circadian rhythm of this contraction. The degradation of the extracellular matrix is assessed by fetal fibronectin detection in cervicovaginal secretions and is also part of the parturition process. When detected between 22 and 37 weeks gestational age, it indicates the disruption of the decidual chronic interface and increased risk of preterm labor. Evidence implicates apoptosis as a critical factor leading in the above process.
Okay, next is the clinical manifestations. Below are something clinical manifestation or signs and symptoms in premature infants, and it is according to Augustine 2020. First is gestational age under equals 37 weeks. Second is body weight under equals 2,500 grams. Third is body length is 46 centimeters, and then head circumference is 33 centimeters. Chest circumference is under equals 30 centimeters. There is still a lot of fine hair that grows on the fetus body while it is still in the womb, or it is called lanugo. And then thin subcutaneous fatty tissue. The earlobe cartilage has not yet grown completely, and then shiny heels and smooth soles. Then looks like the genitalia are not yet perfect. In male babies, the testicles have not descended into the scrotum, and pigmentation in the scrotal area is also lacking. In baby girls, it appears that the labia minora have not been covered by the labia majora, and the clitoris is prominent. Next, inactive movement because muscle tone of the baby is still weak. And then weak cry of the baby, nerve function is not yet effective, and then is mammary gland tissue is less visible due to lack of muscle and fat tissue growth.
Now talk about complications. The first one is maternal complications. Preterm labor has been associated with an increased risk for cardiovascular mortality and morbidity, typically years after the delivery due to unclear reasons. Second one is infant complications. Preterm labor and delivery are associated with the impaired neurodevelopmental outcome, which includes impaired cognitive abilities, motor deficits, cerebral palsy, and vision, also hearing losses. This risk increase with decreasing gestational age. Behavioral issues such as anxiety, depression, autism spectrum disorders, and also ADHD are also associated with preterm labor. The third one is neonatal complications. These include necrotizing enterocolitis, intraventricular hemorrhage, bronchopulmonary dysplasia, retinopathy of immaturity, weak growth, and the presence of congenital anomalies. So, with improved obstetric and neonatal care, the rate of complications in preterm births has decreased. With patient-specific education and follow-up, the long-term sequelae and disability have improved.
Objective data: the baby was born at 32 plus 6 weeks, birth weight 1,122 grams, the baby looked congested, rapid and irregular breathing. Respiration 62 times per minute, there is mild chest wall retraction, there are no additional breath sound, pulse 135 times per minute, temperature 37.1 Celsius, the baby experienced respiratory distress, speed up 3 cc of blood, inadequate suction reflex, OGT installed O2 nasal cannula 2 LPM, the baby has sepsis. Laboratory result on April 3, 2018 include platelets 110,000 UL, MCH H3 8 PG, MCHC H37 gram per DL, MCV H 101 FL. The baby is given an infusion of dextrose 10%, 5 drops per minute.
Okay, so now I will explain about nursing diagnosis. The first nursing diagnosis that we got is ineffective breathing patterns related to neurological immaturity. And the second one is ineffective baby feeding patterns related to prematurity. And the third and for the last one is the risk of ineffective gastrointestinal perfusion. And for the intervention, ineffective breathing patterns, the intervention is first monitor general condition, measure vital signs, monitor speed, rhythm, depth, and difficulty of breathing, note chest movement and use of respiratory muscles to determine whether there is chest wall retraction or not, and auscultate breath sounds and adjust patient position to optimize breathing and preventing aspiration. And the last one is provide oxygen therapy and monitor SpO2 to provide adequate oxygen. For ineffective baby feeding patterns, the intervention is monitor sucking and swallowing reflexes, gently stroke the baby's cheeks to stimulate the sucking or rooting reflex, and monitor the correct placement of the OGT tube, and monitor residue and speed up, and monitor the baby's weight. And for the last one, the risk of ineffective gastrointestinal perfusion, the intervention are monitor signs of bleeding, collaborate with doctors administering drug therapy, monitor parenteral fluid administration, measuring abdominal circumference, and performing breast milk spoiling or gastric lavage per OGT, and taking baby gram x-ray test results. And that's all for the nursing diagnosis and their interventions. Okay, so that's all the explanations for our topic, and if there are any mistake that we made, we are sorry, and thank you guys for watching. See you on the next project. Bye.